So if we look at third-line mantle cell lymphoma, generally this is what we consider patients who relapse after a BTK inhibitor. So outcomes in this patient population have been historically poor. You typically have what we call diminishing returns with successive treatments, meaning you keep treating patients. So if I treat you the first time, you get a certain number of patients that respond. If I treat you the second time, there's a certain number respond, but it's typically less than the first time. And the time the cancer goes away is typically shorter. And with the third line, you continue to get less patients responding and shorter remission. So again, while BTK inhibitors have greatly improved our outcomes in the second line, they've sort of set us up with a scenario where, we have a situation of patients not having very many or any really effective options once the BTK inhibitor stops working. So before recently, there were very few approved drugs that have benefit in this area. We've seen some improvement now with the approval of the CAR-T, which was chimeric antigen receptor therapy treatment with the drug called brexicaptogene that has made significant improvements in this patient population. There is another drug that was recently approved in this setting as well called pirtobrutinib. And then there are other experimental drugs that are coming along the way, which hopefully will improve outcomes in this patient population. So if we look at what was reported before the approval of brexicaptogene, which was that CAR-T treatment, again, chimeric antigen receptor therapy, as you can see, these curves that you can see to the right show very poor responses. Again, you never want to see a curve drop off like a cliff. That means that these are patients who were sort of evaluable and then they subsequently fall off, meaning they have either relapsed or succumbed to the cancer. So again, we struggle quite a bit to try to have very good options for this sort of post-BTK setting. And the majority of patients would relapse or succumb to the disease within the first year after progression from a BTK inhibitor. So when I spoke to certain other drugs that had FDA approval, so there's a drug called venetoclax, which did have some benefit in patients in mantle cell lymphoma, but when we looked at it in this specific patient population, there were two publications that came out, one from the US and one from Britain. And in both of these publications, the key takeaway is that this drug does not work very well. And even patients who do have some sort of response, the response is not very durable, meaning these patients will need another treatment very quickly thereafter. So this was not a winner. Now, what I mentioned before, as far as brexicaptogene, which is a CAR-T product, as I mentioned before, this drug had very excellent efficacy and duration of response in this patient population. So as you can see, the overall response rate of 93% and a complete remission rate of 67%. Again, this was phenomenal and something we had not seen before in this patient population with any other treatment. And a key thing to look at is we do see durability with some of the responses. As you can see, a flattening of these curves, which we call a plateau. That is very important as we see a plateau in the progression-free survival and duration of response, again, with this early phase study. So again, very important treatment. The downside to CAR-T is that you can only get this treatment at very select centers. And it means you have to typically go to an academic center or a large private practice center, which has been approved to give CAR-T. So it's not something that you can go to your every local day community oncologist and get treatment with. So it does limit the availability of this type of treatment. And because with this treatment, you have to have some sort of manufacturing, meaning they take blood cells from you, they ship those cells to a company, the company sort of manufactures them, and those cells are shipped back. What we refer as vein to vein. That time can vary. And again, while we're waiting on the vein to vein time, it's not like your cancer is sitting there idly twiddling its thumb. It is still progressing. So that as well is a limiting factor. So accessibility and the fact that you have to have this manufactured is not something that you can typically just go into the closet and pull off the shelf, does limit some of the accessibility of this treatment in most patients. Another thing to be concerned about with CAR-T is its side effects. So as we see above, cytokine release syndrome and neurotoxicity are two things that occur, which, are things that we do need to be concerned about with this sort of treatment. I think of the two, the bigger concern would be the neurotoxicity, meaning neurological complications from this treatment. As you can see on the box to the right, it occurs very frequently in 63% of the patient, but more concerning is the 31% grade 3 or above, which means that this is the higher the grade, so typically grade 1 to 4, the higher the grade, meaning the more severe the side effect is. So anything grade 3 or above is very severe. And again, a third of those patients had severe toxicity, which is something that could be concerning. As well as you can see that not all patients had resolution of these events at the time of study publication. So again, with CAR T, very effective, but again, accessibility is an issue. Time it takes to get the drugs is an issue, and then the side effects are an issue, which means that we still have more work to do. But as of right now, this is still likely the best option for patients in the post-BTK setting as we continue to try to work to improve upon some of the side effects.